Hello and welcome everybody to ICMDA webinars. I'm Dr. Peter Saunders, the Chief Executive of the International Christian Medical and Dental Association, which brings together over 80 national associations of Christian doctors and dentists throughout the world. And today on ICMDA webinars, we're privileged to have Dr. Walt Larimore back with us, speaking on the issue of using a spiritual history to uncover religious struggle, and I'll introduce him very shortly. So, using a spiritual history to uncover religious struggle. The use of spiritual assessment by health professionals as part of a social history has been considered a vital part of quality whole person healthcare for decades. However, virtually all of the spiritual assessment tools in use today fail to inquire about a critical health factor, religious struggle. And a developing and robust literature shows religious struggle can predict future morbidity and mortality of various types. How can Christian health professionals inquire about and deal with the surprisingly common religious struggles patients encounter? And we've got Dr. Walt Larimore back again. Walt is a family physician. He's the co-author of CMDA's The Saline Solution, from which ICMDA's saline process was developed by International Health Services and is now used by the International Saline Partnership around the world. Walt also was the co-author of CMDA's Grace prescriptions and the inspiration for CMDA's new faith prescriptions. He's been recognized in International Health Professionals of the Year and International Health Scientists of the Year, as well as the 2000 Intellectuals of the 21st Century. So, Walt, it's a real pleasure to have you back again on ICMDA webinars, and we really look forward to hearing what you have to say. Thank you.
Technical issues this morning, so we're going to run the slides there from Great Britain. So hopefully that will work well for us. So this may be one of the most important webinars that you'll attend if you care for patients. Would you be interested in knowing more about a single risk factor that could be present in as few as 10% of your patients, or if you take care of hospitalized patients, as many as 50% of your patients, and this single risk factor can increase their risk of mortality by 16 to 28% over the next 2 years. And it's a risk factor that you could uncover in just a couple of minutes at no cost. Would you be interested in that? Well, that's what we're going to talk about today. Next slide. Last time, our last webinar that we did, we talked about the basics of taking a spiritual history, a spiritual assessment. If that's something that's not familiar to you, there's a review article that's available to you, and information will come out to you tomorrow in an email of how you can obtain that. Next slide. Today's presentation is going to be talking about a little bit more advanced spiritual assessment, one that's designed to discover religious struggle using an acrostic in English called the Lord's Lap. Those of you who are proficient in other languages, I hope that this webinar will be stimulating to you to develop your own acrostic in your language to help clinicians and healthcare professionals remember this easy-to-use spiritual tool. Next slide. So there's a number of evidence-based reasons. Peter indicated that for decades, a spiritual assessment has been considered part of quality patient care, irrespective of the healthcare professionals' religious leanings, one way or the other. The spiritual assessment is appropriate for atheists or agnostics or healthcare professionals of any religious persuasion to be able to use. But what a wonderful tool that it is for those of us who profess to be followers of Jesus. And obviously, the literature reasons are that patients desire that we ask about their spiritual beliefs. Not every patient, but most. It benefits the patients when we ask about their belief. It enhances the relationship between the patient and the healthcare professional. And as both Dr. Saunders and I have alluded to, it's now considered a standard in quality patient care. But it also has an additional benefit, and that's that it identifies religious struggle, any religious struggle that a patient may have. Next slide. So there are negative effects of religious struggle. Patients who feel alienated from or unloved by God or punished by God or the devil have, and here's the data from almost 22 years ago, showing that patients have a 16 to 28% increase in the risk of dying in a 2-year follow-up period. And you'll see the little acrostic there in English that patients who feel alienated or unloved, and let's give love that capital L, and patients who feel abandoned by God or the spirits or a higher power. That's the A, if you would, of the LAP, L-A-P acrostic. And then patients who feel punished by God or a higher power, or feel punished by evil spirits or the devil or pantheistic guides, that these patients have a dramatically increased risk of mortality, not just morbidity, but mortality. So in English, I call these three the LAP factors. And let's just look very quickly at a few studies that outline the negative effects of these. Next slide. So this is a study of adults with a wide variety of medical conditions: traumatic brain injury, spinal cord injury, stroke, patients who had a TIA, a transient ischemic attack, patients with cancer, a wide variety of primary care disorders, abnormal cholesterol, hypertension, cardiovascular disease. The literature shows that patients with any degree of negative spiritual belief, for example, feeling abandoned or punishment from a higher power, those patients have significantly worse bodily pain, significantly worse physical health, significantly worse mental health, and a lower level of forgiveness. They have more anger, more cynicism, more bitterness. Next slide. So you can see in this abstract from this study that these patients have abandonment and punishment problems. Here's another study that concludes that any degree of negative spiritual belief, regardless of positive spiritual beliefs, is associated with worse health outcomes. You have a patient that comes in, maybe they are in your faith community, maybe they're your pastor, maybe they're an elder or a deacon or a spiritual leader in your community. If that person, no matter how many positive spiritual beliefs they have, has a negative spiritual belief, they're going to have a worse health outcome. And if your practice is like mine was for 20 or 25 years, I never knew it because I didn't know how to ask about it. Next slide, Josh. This is another example. This is a meta-analysis with data on over 44,000 patients, showed that patients with high levels of religious or spiritual distress were associated with poorer perceptions of health and poorer outcomes. Next slide. So the bottom line is that there's a growing body of really quality medical and social science research showing harmful effects, both morbidity, worsening disease and distress, and mortality, worsening death rates, premature death, earlier death, with religious or spiritual struggle among patients with a wide variety of diagnoses. And this particular group of clinicians concluded that clinicians, healthcare professionals, should be attentive to signs of religious struggle. Next slide. So medical care providers, we need to be attuned to the dark side of our religious and spiritual patients that can include, as these researchers say, patients who struggle with an existential level or a feeling of disconnected with God or spirituality or religion or religiousness or a higher power. And healthcare professionals in general, doctors in particular, are better able to provide patients with supportive care resources when they assess them early for spiritual distress. Now, you may say, well, I'm very busy. I've got scores of patients to see. My clinic, my office, my surgery is just packed. I think I'll leave this to the chaplains or to the intake officers. And next slide. What the literature tells us is that patients with spiritual distress, patients with spiritual struggle, without their doctor, without their healthcare professionals' encouragement, may refuse to speak to clergy. Why? Because they're angry with God, or they're angry with a higher power, or they feel abandoned by the higher power, or they feel punished by the higher power. And in comes their priest or pastor or monk. And are they going to speak with them? Well, the literature says they tend not to, because they've cut themselves off from this source of support. Next slide. So where patients' response indicate possible spiritual struggle, healthcare professionals have the opportunity to learn about that in a way that almost no one else in the healthcare system can. We may not be trained, capable, or able to take care of it. We may not have the time to take care of it, but we can become the triage officer. We can become the trusted professional that the patient can share their heart with. And then we can do a referral to a chaplain or to a pastoral counselor to help the patient with these particular problems. Next slide. So the negative effects of religious struggle in English, I call them the LAP factors. Those of you, as I said earlier, in other languages, I bet Dr. Saunders and ICMDA would love to have you develop this tool in your language so that we at ICMDA can help disseminate that to healthcare professionals who speak your language or who converse in your dialect to be able to use this crucial healthcare tool. But let's just go for English. The LAP factors, again, the L for unloved, the A for abandoned, the P for punished, and it kind of has a two-prong approach there, either punished by a good spirit, by God, by a higher power, however the patient defines that religiously or spiritually, but also the literature dissects out patients who feel punished by evil spirits or by the devil. Next slide. And I'm not going to go much into the data here. I just want you to see that for the unloved patient, for example, next slide in, Josh, for patients who question God's love for them or a higher power's love for them, they have a 22% increased relative risk of mortality in the next 24 months. Not morbidity. This is a study of mortality. It's almost 1/4 increased risk with this single risk factor, that my cancer, my pregnancy, my abscess tooth, my cardiovascular disease, whatever my problem is, if that problem makes me question God's love for me, I'm at risk. Next slide. The next part of the LAP acrostic is people who feel abandoned by God, people who wonder whether God has abandoned them, or for patients who come from prayer backgrounds or charismatic or Pentecostal backgrounds who have prayed a healing prayer, and that prayer has been answered with either no or wait. Those patients are at the highest risk, a 28% increased risk, not of morbidity, but of mortality in the next 2 years after you see them. Next slide. And then the next factors are those who feel punished by God or punished by a higher power, or punished by evil spirits, or punished by the devil. In the case of punished by God, either for lack of devotion or for past sins or for past wrongdoing, a 16% increased risk of mortality. And it's even worse if they feel punished by the devil or punished by evil spirits. That goes up to a 19% increased risk of mortality. Well, if you're convinced that this is a risk factor that is real, that is significant, and if you're convicted, as I was about 15 years ago, that I never asked about it. In fact, I didn't even believe it existed. I just thought in my patients, I'm not sure this is there. But when my partners and I added these lap factors to our basic spiritual assessment, we discovered it was there. We had never asked about it, and so our patients never told us about it. Once we began to ask, then they began to open up to us. Now, if you've watched our initial training on a spiritual assessment, next slide, the basic spiritual assessment, there's lots of them in the literature. There's the HOPE questionnaire. In English, there's the spiritual questionnaire. There's the spirit questionnaire. There's the FICA questionnaire. There's just gobs of them. The one that we tend to use in ICMDA and in the saline process is a very simple one. It's called the God questionnaire. And the English acrostic for God is just 3 basic questions that you add to your social history. If you're asking about alcohol use, or you're asking about employment, or if you're asking about tobacco use, you add a spiritual history, 3 simple questions using a God acrostic. Next slide. So the G is God. So may I ask about your faith background? Do you have a spiritual or faith preference? Is that something that's important to you now, or was it important to you in the past? Is it something you participate in, or is it something that's not really that big a deal in your life? That's kind of the God questions. In our training, we train practitioners and healthcare professionals. It's not the specific questions. You adapt these questions to your temperament, to your personality, to your practice, but to ask them where they are in relationship to God or a higher power. The G questions. The O of the God acrostic is others. Are you now, or have you ever been part of a religious community or a spiritual community? Kind of like if you ask, do you use tobacco? And they say yes. Or do you use alcohol products? And they say yes. The follow-up question, oh, well, how often? How much? What do you use? And same thing with the God questions. Are you a part of a religious or spiritual community? And they say yes. Oh, well, what community? How often? If not now, how often in the past? How important was this to you? And then the D of the basic spiritual questionnaire is just a do. What can I do to help incorporate your faith into your medical care? Do you have any spiritual beliefs that I need to be aware of? Do you need any religious resources or materials? Can I pray with you? Or may I have others pray with you? Next slide, Josh. There's another article in the medical literature that gives these 3 do questions. Is there a way in which you would like for us to account for spirituality in your care? Is there a way we can provide spiritual support, or our system or our clinic can provide spiritual support? Are there resources in your faith community that you'd like me to help mobilize? Would you like me to contact your pastor, your priest, your rabbi, your monk, your spiritual leader to come see you? So next slide. So the God questions, we've taught these in ICMDA and the saline process for, my gosh, close to 3 decades. But these simple questions, these God questions, completely ignore any religious struggles that a patient may be having. So the new acrostic that I use, next slide, Josh, is I call them the Lord's Lap. And once again, I can't wait to see these develop into Spanish and Russian and Arabic and languages literally around the world. But in English, the Lord's Lap questions can help you explore within just a minute or 2 whether your patients are struggling with religious or spiritual issues or not. And so our basic acrostic has gone from the God questions to the Lord's questions, and it's not hard. It's just as easy as the God's questions. And let me show you why. The Lord's Lap questions, next slide, we have, go back one, Josh. Sorry. So the Lord question is the God question, LG. The others in the Lord acrostic is the same as God. It's the others in God. Then there's a new R, that's religious struggle or relationship. I'll tell you about that in a minute. And then the D is the same as the God questions. It's what can we do for you? So let's look at those just real quickly. Next slide. So the Lord, the L of the acrostic, Lord is the same as God. May I ask about your faith background? Do you have a spiritual or faith preference? And then the O, the next slide, is the same as the God's question. It's others. Are you now, or have you ever been part of a religious or spiritual community? If so, how often, how it's important to you? And then we come to the new part, the religious struggle part. And for the R, at least in English, we talk about, do you have a religious struggle? And if you don't, I'm going to talk to you about how you can build a relationship with a patient spiritually. So the point here is, after asking the L questions, the Lord or God question, after asking the O or the others, you will have a pretty good idea of whether religion or spirituality either are important to your patient or have ever been important to the patient or not. The atheist and the agnostic, you'll know that. And then for all your other patients who either now or ever have had any sort of religious or spiritual background, you'll know them. And we're not talking about whether they're Christian or not. It's just not talking about whether they're a follower of Jesus, but whether spirituality or religiousness is something that is or was important to them. Because if that's the case, they may be wrestling with spiritual struggle. Next slide. So the R of the Lord acrostic in English looks at either religious struggle or religious or relationship. Now, what I mean with the religious struggle part of this acrostic is, if you sense your patient is or was religious, then explore religious struggles with them. I kind of think of it this way. In my mind, I don't ask them this, but in my mind, I'm asking, are they in the Lord's lap? Or have they fallen or crawled off of the Lord's lap? Is their religion or spirituality supportive to them, or has it fallen away in importance? And the lap questions are the way to do that. Next slide. So it's just those simple 3 questions. Does this disease, this disorder, this issue you're wrestling, does it cause you to question God's love for you? Or do you think that this issue that you're wrestling with has caused God to abandon you? Now, you may not use God language. It may be that your patient population, you use Allah or higher power or whatever it is that the patient declares is important in their religiousness or their spirituality. But do you question God's love for you? A, abandoned. Do you think God's abandoned you? Or have you asked God to heal you? Have you prayed to him and he hasn't? Has he abandoned you? And then the P, do you believe God or the devil is punishing you for something? Do you believe that the spirit world is punishing you for something? And it's been stunning to me for patients who I just didn't think that any of these would be the case, that one or more of them are. I was working with some residents, and one of the residents was asking a pastor these questions and went through the L question, do you question God's love for you? And this pastor said, absolutely not. I know God loves me. And, well, do you think God's abandoned you? And this pastor said, absolutely not. I know that he will never leave me. He will never forsake me, that nothing can pull me out of his hand. And then the resident didn't ask the punish question. And we were at the bedside, and I said, well, what about the P question? And she said, well, I mean, obviously it's going to be negative because the first 2 questions were negative. And I said, well, let's just ask. And so she said, do you believe God or the devil is punishing you for something? And this man's lips began to quiver. His eyes misted up. And he said, yes, I've done something terrible, and I think God's punishing me. That pastor's risk of mortality in the next 2 years is about 20% higher. And we would not have known that without asking. Next slide. Now, suppose that after asking the L and the O questions, that you sense the patient really has no religious struggle, no religious background at all, or they have a religious background with no religious struggle. You ask the lap questions and they're all negative. Well, then there's the opportunity of bringing spirituality, bringing your Christianity, bringing your faith into the conversation. So if you sense a patient has no religious struggle, you can use this moment in your social history to very quickly build a relationship with the patient. And you can let the patient know, I like to think of it this way. You're not dealing with the Lord's lap, but I want you to know I'm in the Lord's lap. And here's a couple of ways you can do that using what we call a faith flag or a faith story. Josh, next slide. So one way that you might think about doing is something like this. Even though religion, spirituality are something that's not important to you, I see patients every day who when they begin to wrestle with a spiritual issue, when they begin to wrestle with a healthcare issue or even a difficult healthcare decision, very often patients begin to have spiritual thoughts or spiritual questions. When a woman becomes pregnant, it's not at all unusual for her to begin to think about spiritual issues, even if she's not spiritual, as she begins, as that little baby's starting to grow into her. And so to be able to tell that patient, listen, I know with the issue you're wrestling with, sometimes patients will begin to think about spiritual or religious thoughts. And I want you to know, if you ever want to discuss these things, let me know. So it's a way of opening a door to them. And then you move on to your next question. Next slide, Josh. Or perhaps it would be a faith flag, something like, even though religion and spirituality are not important to you, I'd like you to know that I have a personal relationship with God, or that my personal relationship with Jesus is the most important thing in my life. However you wish to word that in the environment that you're in the institution where you work, under the constraints of where you practice, but to let someone know my personal relationship, my personal spiritual relationship, my personal religion, my personal relationship with God is the most important thing in my life. And so with your permission, I'll be asking for his wisdom and guidance as I care for you. Is that okay? I've never had a patient say no. Now, I've had 3 patients say no when I asked them if I could pray with them, but never in over 40 years of practice have I had a patient say no, that they wouldn't want me to pray for them on their own. And then the last part of the Lord's acrostic is the do questions. And that's exactly the same as the God summary. Now, I've covered this very, very quickly, but just to summarize, and then we can talk a little bit more about it. The current evidence in the medical literature, this isn't in the religious literature, it's not in the spiritual literature, it's in the social science literature, it's in the nursing literature, it's in physicians' literature. But the current evidence would encourage physicians in specific, healthcare providers in general, and healthcare systems to learn to assess their patients' spiritual health and to provide indicated and desired spiritual intervention. I've worked with any number of systems that, once they became aware of this literature, began to institute a spiritual history, a religious history, as part of the intake history of that institution. Next slide. Because of this, assessing and integrating patient spirituality into healthcare, it can build trust, it can build rapport, it can broaden your relationship with the patient, and it can increase the effectiveness of the relationship. So we're going to open it up now for questions and comments. I apologize for being a fire hose. I apologize for giving you so much information so quickly. But in tomorrow's email that Josh is going to send out to you, it will have these slides available to you, which have all the references. You can use them, you can copy them, you can plagiarize them. If you want this PowerPoint presentation to use and take credit for, it's yours. It's yours free for the asking. Also, I've published 2 review articles, one on a basic spiritual assessment with all of the citations and all of the references available, and also another review article on an advanced spiritual assessment, this Lord's Lap assessment. Both of those will be available for you tomorrow just by the asking. We're absolutely happy to send them to you. And I want you to know that I'll be praying that as you begin to pray and consider including this risk assessment tool into your practice and with your patients, that God will richly benefit you in your spiritual growth and the spiritual care that you're able to give others. So, Peter, with that, happy to address what I'm sure will be some wonderful questions.
Thanks very much, Walt, for a really inspiring talk, informative, evidence-based. spiritual. So first of all, Walt, we've got a question from Rod McRory in the UK. Have you had any experience in preventive care in this area by way of training our pastors to counter negative religious effects? Now, you mentioned that the last person someone with religious struggle wants to see is a pastor, but is there any training that you've been able to do or would recommend for pastors in this whole area? And I mean, at very least, educating them about the links between spiritual struggle and health.
Yeah, Rob, thank you so much for that question, because it brings up a point that I didn't bring up that's just crucial. With patients with religious struggle, excuse me, chaplains, pastors, Christian psychologists, Christian psychiatrists who have experience and training in dealing with patients who are wrestling with religious struggle will tell you that this is a very complex issue. It takes time to help people explore this and wrestle with it and struggle with it and overcome it. It's not something that most healthcare professionals have the time or expertise to handle, and therefore working with chaplains, with pastors, with pastoral professionals, with Christian psychologists is critical. And so if wherever you're in practice, you and or others begin to explore this and figure out how are we going to fit this into our practice, whether it's a preventative practice or acute care practice or a hospital practice, but in whatever our milieu, how are we going to introduce this into our social history, our intake history? Obviously, with acute patients that have come in a code, we're not going to be doing this, but at some point in our care, how do we address these issues? Because if we're going to address religious struggle, then we need to have the resources for folks that we can use for consultation or referral. And so that has led to many discussions that I've had, not only in this country, but other countries with, say, for example, a hospital or a clinic system that's going to incorporate a spiritual history. Then whoever the spiritual care is of that system, whether it's chaplains, pastors, pastoral professionals, then to meet with them to say, hey, our healthcare professionals are going to begin to learn this. We're going to begin to experiment with this. We're going to begin to try to do this. And if so, at least according to the literature, we're going to find some people wrestling with this. And we need to be able to do referrals. Are you comfortable with that? And if you're comfortable with that, how do I refer people to you? Do they come to your faith institution, to your church? Do they come to your synagogue? Do they come to your temple? Because remember, our goal is to meet people where they're at. Cultivation comes with people coming to trust a Christian, not trust Christ. And so I'm willing to work with spiritual leaders of all stripes who are willing to help their patients with this issue. I hope that it'll lead for opportunities for me to share my faith down the road. But anyway, working with the para-professional spiritual community is just critical. And so, Rob, once you begin doing this in your system, or if you're already doing it in your system, then to begin to recruit those outside of the system who can come alongside you to help care for these patients can be critical. Great question. Thank you.
Thanks, Walt. Now, you talked a lot about the importance, the link between spiritual or religious struggle and ill health, and you've given us a brilliant set of questions to be able to diagnose religious struggle. And we haven't had the time to talk about what you then do in terms of managing religious struggle. And you've been talking a little bit about referral now, but in normal circumstances, if as a doctor we can make a diagnosis, we then got to ask ourselves the question, is this a problem I can deal with, or does it require referral? So how would you advise the doctor who is using these questions uncovering religious struggle in terms of knowing, what you try and deal with yourself, and if so, what are good ways of preparing for that? Or on the other hand, what do you refer and who do you refer to?
Yeah, well, oftentimes I find, particularly in younger Christian professionals, both younger in age and also younger in their faith walk, that there's often duality. In other words, we have the world, the healthcare world, and then we have our spirituality, or our spiritual relationship with God. And very often those two don't cross. We don't realize how the world and how Satan has made us dichotomous, how it's separated us. And instead of being whole Christians in our healthcare, we tend to be separate. And let me give you an example. So what that question indicates, well, let me take that question another way. If I'm going to ask people about alcohol use, and I come to a patient, I say, do you use alcohol? And the patient says, yes. And I say, well, how often and what? So I drink a quart of vodka every day. Is that a potential health problem? Absolutely. Physical health, mental health, relational health, and spiritual health are all impacted by alcoholism. Now, I'm going to run into that in patient care. So I either need to know how to care for that or how to refer for that if I don't care for that, or how to co-care for that with other specialists. I may do the same thing with tobacco, or I may do the same thing with a pregnant patient who needs labor support that I'm not going to provide, but I need to have doulas or other paraprofessionals or midwives who are going to come into care with me. Same thing with spiritual care. So if I'm going to begin to root around to discover if there's an issue in spirituality that's affecting the patient, I'm going to find it. And then what do I do with it? Well, I either need to develop some expertise or some training in how to care for religious struggle, or I need to have others that I can refer to, the same way I do for everything else in my practice. As a family physician, I need to know cardiologists and neurologists and neurosurgeons and general surgeons and obstetrician gynecologists. I need to have other professionals I can refer to. As a sports medicine physician, as a family physician does sports medicine, I need to have orthopedic surgeons backing me up and sports psychologists that I work with. So the same thing in this area of religious struggle. If as you learn more about it and as you begin to ask about it, then to begin to ask yourself, is this something I feel that the Lord's leading me to provide some basic care in or to refer for? In the article that you'll be sent tomorrow, there's a number of citations that you can look up. Most of them are available online to begin to explore, how do I treat religious struggle? How do I approach it? And it might be, Peter, a nice webinar for the future, because it would take some time to go in depth on it. But great question.
Yeah, that would be great. Now, I come from a church where a couple of centuries ago, there was a man who was suffering terrible depression. And his doctor was a psychiatrist, mental health physician, who was also a member of our church. And he used to leave Bible verses around the hospital for this man. And actually, in reading these, he came to faith and was converted and became the leading poet and hymn writer of the evangelical revival. His name was William Cowper. Now, is there a place for the use of scripture in the consultation? Because particularly with a Christian patient who believing God doesn't love me, God's abandoned me, God's punishing me, and this is why I'm sick. Some of the treatment is going to be in terms of receiving and accepting God's truth. So to what extent would you use scripture in a consultation? And do you have any resources that you've developed in terms of scriptural or truth prescriptions, if you like, for people who are struggling with one of these three questions?
Yeah, great question. In the saline process, we talk about a wide variety of spiritual interventions. We talk about having a spiritual black bag of interventions that are available as we care for patients. So there are a number of those spiritual interventions that can be appropriate here. For example, I mentioned a faith flag or a faith story, where for the patient who's not religious, being able to let them know that religiousness, spirituality, a personal relationship with God is something that I have, and therefore I'd be delighted if you wish to pray with you about this, to pray for you about this. Or because of my personal relationship with God, I've come to realize, I'm just saying what I might say to a patient, I've come to realize the importance of God's word. I believe God's my creator, and that he has designed me and he has a plan for me. And there's a little operator's manual that he's made available to us called the Bible. And the Bible has many verses that touch on this problem. Could I share those with you? You might do that via a handout. You might have scripture that you've memorized for occasions like this, that you're willing to share with patients, doing it with permission. You might have other resources. You might develop a handout. You might use, available online is the Billy Graham Counselor's Guide. It has hundreds of Bible verses organized into topics. Patients are dealing with anxiety or depression or divorce or what have you, that can be available. There are many scripture translations, many Bibles that will have verses organized by areas of religious or spiritual conflict. So there are many resources that you could consider using. They'll be different from practice to practice, person to person, personality to personality. If you wanted to dive a bit deeper, Peter, maybe tomorrow in the email, we can include information about the saline process so that our viewers today can begin to explore, well, gosh, not just the spiritual history, but what do I do with that information? And what are the spiritual interventions that I can use? Do I share scripture with every patient? No, but no more than I do anything with every patient. My job is to find out, what are the issues with which my patient's wrestling? How do I prioritize that? What are the options for each of those issues? And the risk, the benefit, and cost of each issue. So it's a very complex calculus that goes on, but it does allow, at least I need to have some options on what I'm going to do. And you need to develop those. If you're going to explore religious struggle, and I encourage you to, then also explore, well, how am I and how is our system going to begin to deal with that?
Thank you. And you've answered one of our other questions, which was from Jorge Pinzon saying, how can I receive training in the saline solution method? So, and particularly in Spanish, he's asking about. So we'll include some links and information about that in your letter as well. Now, Hedwin Cadrianto and Kananthi are both asking pretty much the same question about a formal questionnaire that takes religious struggle into account. And you talked about the well-recognized spiritual question sieves that people can use, of which GOD is a good example. And you've introduced to us the LORD Lord set of questions. Is this set of questions recognized in the literature and practiced elsewhere or taught in medical schools or postgraduate institutions? Who can people refer to as a kind of literature-based reference to this?
Yeah, the handout, the article is coming to you, and the citations that I referred to today talk about the literature behind religious struggle. There are myriad religious struggle questionnaires that are available. For example, the first big study that came out, the one that I showed you that came from Duke University in the United States, that looked at, it used a religious struggle questionnaire that had 16 questions. I developed the lap questions from the four, FOUR, the four questions that had the highest association with mortality, and then developed the lap acrostic from those four questions. And that was love of God, abandonment by God, punishment by God, or the devil. But each of the articles that are cited use different religious struggle questionnaires. If you didn't want to use the Lord's Lap, you could look at those published questionnaires and decide, is there a questionnaire? Is there a way of asking these questions that would work better in my system, in my language, in my situation, in my temperament? And those can be asked verbally. They can also be asked on a computer questionnaire, on our filled out questionnaire. A large Christian health system in Chicago in the US that uses a computerized medical record actually developed the Lord's Lap in a intake form that all of their patients fill out when they come to the clinic, and then the clinicians are able to look at that and look at the answers to those questions and go further into it. The caution that I give you is that it appears the further that question is from the actual healthcare professional, the more likely the patient is to lie. Now, they're not lying to deceive you. It's just, especially with a new patient, they're not sure they can trust you. And this is deeply personal and difficult information. So it appears, for example, that if these questions are asked by the healthcare professional as opposed to the chaplain, if you would, or as opposed to a unit secretary, or as opposed to an intake clerk, that the healthcare professional is more likely to get a truthful, accurate answer to that. And so, but can it be done in a written form or computerized form? Absolutely. And there's examples in the citations of how to do that.
There's another question here. Well, you've given us a great challenge, first of all, as ICMDA, as an international community, to develop easily memorable acrostics in the main languages. We work in 7 main languages across the world. It would be great to see how LORD might transcribe to those bilingual and multilingual individuals we've got listening today. Tae-Young Hong is asking, it's a question you've in a sense already asked, but if people who are skeptical of the causal link between religious struggle and increased mortality, can you elaborate on the evidence in the literature that supports your view? And you've mentioned several papers already, and we're going to include those in the letter we write tomorrow, but is there any, perhaps one place where people might go to see this or find it all summarized?
Yeah, let's be clear, there is no causal link. In other words, all of this data is associative data, population-based data, but yeah, all of you who are used to dealing with medical research and medical data understand that where areas where causal information is not available, associative or population data can become crucial, at least giving us guides towards where truth is. When the initial paper came out from Duke, I believe that was 2002, there was great questioning about that because the findings were so shocking that people really were skeptical of them, even though it was a multifactorial paper. In other words, they dissected out as many factors as they had available of disease burden and demographics, etc. It was associative data, if you would, not necessarily cause and effect. But with associative data, as you begin to build more and more and more and more, as you have meta-analyses that involve 40, 60, 80,000 people, then you begin to go, okay, maybe this is something I can begin to think of as truth. In our case, in my practice back then, when we first saw this data, we were a bit skeptical. But as we began to practice it, as we developed the Lord's Lap and began to use it and found, my gosh, people, I never thought anyone was struggling with this. And then I found out patients were. Hospitalized patients at a greater percentage than non-hospitalized patients. In Tulsa, Oklahoma, there's a Christian residency called In His Image. And I've had the privilege of being a adjunct faculty there for the last almost 20 years. And when we started looking at the hospitalized population in Tulsa, we found that 47% of the inpatients that we dealt with when we used the Lord's Lap were wrestling with spiritual struggle. So it became really real to us. And whether or not that religious struggle actually causes the morbidity or mortality seems to me to be a little less important than the fact that it clearly is distressing the patient. And so meeting them where they're at means coming alongside them and helping with the many, many steps as God draws them to himself. So if it's distressing to them, to be able to come alongside, recognize that distress, validate that distress, and then to begin to give that patient help and hope that that distress can be treated, it can be calmed, and it can be dealt with. It's just a very powerful clinical and spiritual tool. And I'm just delighted to be able to share it with you.
We've almost run out of time, sadly, Walt, but there's a couple of questions asking the same thing here. Has this been looked at in healthy individuals as opposed to ill individuals? In other words, people who are healthy but believe that God doesn't love them, he's abandoned them, he's punishing them in some way. Does that have a correlation with ill health and specifically mortality going forward?
Yeah,
is there any
great
data
question.
on that?
There is an association between a patient having no health concerns and having extreme health concerns. And so religious struggle tends to be more common as the disease burden, as the disease severity goes up, so that a patient struggling with a terminal disease or with cancer or with a very difficult to treat disease, patients with chronic disease in particular are much more likely to be wrestling with religious struggle than someone who just turned an ankle or who has a sore throat. The spiritual questions, the God questions, are recommended for all patients, but once again, being most acceptable by patients who are on the more severe end of it. So the God questions are to me more useful in preventative care, because people tend not to be dealing with religious struggle, at least as far as health concerns, as opposed to people with chronic disease, more severe disease, or terminal disease. Great question.
Yeah. Well, thank you so much, Walt. And we will certainly take you up on your offer of coming back yet again in the future. And maybe that question of therapeutic pathways for people with religious struggle, to unpack that a bit. You know, once I've discovered this, what do I do to help this person going forward? So thanks, Walt, again for sharing your long experience, giving us the literature, giving us your biblical and pastoral perspective as well. And I'm sure that this will have really stimulated and helped a lot of people today. And we really want to take seriously that question of how we make this much more easily accessible to people and memorable to people in different language groups as well within ICMDA. So thank you, brother. Thanks to all of you for coming and making it a success. And we'll see you again. I'm Dr. Peter Saunders, the CEO of ICMDA. God bless you.